I'm Dr. Kilpatrick. Decoding postmenopausal hyperandrogenism can be very challenging. Today, we are going to architect a triage algorithm.
This graph shows the physiological baseline of a woman entering menopause. As the blue line indicating estrogen levels plummets, the red line representing androgen production remains relatively stable. This widening gap creates a natural state of relative hyperandrogenism in the female body. Physicians expect to see minor cosmetic changes resulting from this hormonal shift. However, a distinct boundary exists between these expected physiological adjustments and the presentation of severe, new-onset hyperandrogenism. When an older patient presents with sudden, aggressive virilization, conditions like idiopathic hirsutism or residual polycystic ovary syndrome cannot account for the rapid physical changes. Polycystic ovary syndrome is a common endocrine disorder, causing irregular menstrual cycles and mild androgen excess. This presents endocrinologists with a strict diagnostic dilemma. They must distinguish between two distinct underlying pathologies that present with nearly identical outward symptoms. This biological schematic compares the first pathology against normal anatomy. Ovarian hyperkykiosis is a benign, functional disorder characterized by bilateral stromal hyperplasia, where both ovaries become symmetrically enlarged and hyperactive. Conversely, androgen-secreting tumors pose an immediate threat to the patient's life. These are typically unilateral, neoplastic masses that require rapid surgical intervention. Navigating the overlap between a benign hyperactive stroma and a lethal neoplasm requires a foolproof, evidence-based diagnostic algorithm to triage patients systematically. Without a rigid framework to separate functional disorders from neoplastic threats, clinicians risk two severe outcomes: fatal delays in identifying malignancies, or subjecting a patient to unnecessary invasive procedures for a benign condition. Before entering the algorithm, clinicians must execute a mandatory prerequisite step, ruling out exogenous androgen exposure. Topical testosterone creams or hormone replacements are the most common cause of isolated testosterone elevations in this demographic. This decision tree begins with the first official node, identifying the clinical tempo of the patient's symptom onset. The path diverges into a gradual onset of more than 5 years and a rapid onset of less than 2 years. Following the left branch, an indolent progression of mild hair growth points toward functional causes, like hyperthecosis. Following the right branch, sudden symptoms in under 2 years act as a glaring clinical warning. This short timeline mandates an immediate hunt for a neoplasm. The physical examination must differentiate between simple hirsutism, excessive terminal hair growth, and true virilization. Virilization implies a state of severe, prolonged exposure to autonomous, high-level hormone production. The first quantifiable physical marker of virilization is clitoromegaly. A clitoral index exceeding 35 square millimeters crosses the strict pathological threshold. The second marker is barophonia, an irreversible deepening of the voice. This is directly caused by androgen-induced hypertrophy of the vocal cords. The third and fourth markers include the rapid onset of Ebling type 3 alopecia and an anabolic increase in muscle mass. Ebling type 3 denotes significant female pattern hair loss with frontotemporal recession and thinning at the vertex. Detecting any of these severe signs immediately overrides other clinical assumptions. The patient is locked into the urgent pathway, regardless of their initial timeline. The speed and severity of these anatomical changes establish the vital first filter, accurately categorizing the probability that a patient harbors a life-threatening tumor. Moving to the biochemical evaluation node, clinicians must abandon standard direct-free testosterone immunoassays. These common tests lack the specificity required at the extremely low hormone concentrations found in postmenopausal women. Accurate androgen measurement in this demographic mandates the use of LC-MS-MS. For true accuracy, liquid chromatography tandem mass spectrometry is utilized. This technique physically separates and strictly identifies complex molecules precisely based on their mass-to-charge ratio. This expanded diagram shows the primary biochemical red flag, a total testosterone level greater than 5 nanomoles per liter. Crossing this central threshold places the patient in the critical danger zone for neoplasms. To separate an adrenal source from an ovarian source, the tree branches based on DHEAS levels, utilizing a threshold of 700 to 800 micrograms per deciliter. Dehydroepiandrosterone sulfate is a circulating steroid hormone produced almost exclusively by the adrenal glands. An extreme warning threshold exists on this branch. DHEAS levels exceeding 6,000 nanograms per milliliter almost exclusively signal the presence of an adrenal carcinoma. Conversely, if DHEAS remains normal, but total testosterone is severely elevated, the algorithm isolates the ovaries as the source of the excess androgen. A crucial physiological caveat complicates the interpretation of these numbers. Following menopause, women experience a natural decline in sex hormone-binding globulin. This is a liver-produced protein that binds to sex hormones in the blood, regulating their active availability to tissues. Comorbidities such as insulin resistance and obesity further suppress these protein levels in postmenopausal patients. Suppressed binding proteins artificially inflate the free androgen index, amplifying the biological impact of the circulating hormones. The free androgen index is a ratio used to estimate the amount of biologically active testosterone circulating in the bloodstream. Because of this drop in binding capacity, even a modest elevation in total testosterone triggers severe systemic effects. Strict mass spectrometry thresholds serve as the ultimate arbiter when clinical histories appear ambiguous. The localization step directly challenges the standard gynecological instinct to utilize TVUS as the universal first-line imaging tool. Transvaginal ultrasound is an imaging technique using high-frequency sound waves from a probe inserted into the vaginal canal. Postmenopausal ovaries undergo rapid atrophy, shrinking down to an upper volume limit of just 5.0 cubic centimeters, with internal structures becoming dense and obscured. Due to this severe atrophy, small isoechoic virilizing tumors easily evade sonographic detection, resulting in an unacceptable false negative rate. Transvaginal ultrasound is reserved strictly as a first-line tool for the CALM pathway, where patients exhibit no virilization and present with low testosterone levels. The urgent pathway dictates a different protocol. An abdominal pelvic CT is the mandatory first-line choice when biochemical red flags appear. Computed tomography is a medical imaging method utilizing multiple X-ray measurements to produce cross-sectional images of the body. Computed tomography provides high sensitivity for detecting adrenal nodules as small as 5 millimeters. This resolution is crucial for ruling out deadly adrenal carcinomas. The wide field of view provided by a pelvic scan also captures aggressive ovarian neoplasms and metastatic sources like Krukenberg tumors. A Krukenberg tumor is a rare metastatic cancer of the ovary that typically originates in the gastrointestinal tract. A specific diagnostic gap occurs when both the computed tomography and ultrasound return negative results, yet the biochemical markers strictly isolate an ovarian source. In this scenario, contrast-enhanced pelvic MRI serves as the ultimate second-line localizer. Magnetic resonance imaging uses strong magnetic fields and radio waves to generate detailed anatomical images, offering a 78% sensitivity for detecting elusive microtumors. Matching the specific imaging modality directly to the patient's biochemical triage status prevents fatal delays in locating hidden malignancies. Clinicians relying exclusively on the clinical timeline heuristic often fall into the indolent tumor paradox. While a rapid symptom onset highly correlates with a tumor, the reverse rule fails. Specific slow-growing malignancies break the established timeline parameters. Adult granulosa cell tumors provide the primary example of this paradox, developing slowly over a 5-year period. These are rare malignant ovarian neoplasms arising from sex cord stromal cells. This 5-year timeline perfectly mimics the slow, indolent progression of benign ovarian hyperthecosis, creating a dangerous diagnostic illusion. This composite chart juxtaposes the failsafe built into the algorithm. When a slow 5-year clinical timeline clashes with a sudden, massive vertical spike in mass spectrometry testosterone data, the biochemistry must overrule the timeline. Faced with conflicting data, physicians must trust the laboratory results and immediately escalate the patient to advanced magnetic resonance imaging. Even with flawless imaging execution, a terminal diagnostic wall remains. Preoperatively distinguishing severe ovarian hyperthecosis from a small Leydig cell tumor is exceedingly difficult. A Leydig cell tumor is an exceptionally rare, usually benign, ovarian mass that secretes high levels of testosterone. The algorithm resolves all localized ovarian sources at a final terminal node, bilateral salpingo-oophorectomy. This is the surgical removal of both ovaries and both fallopian tubes. This single surgical intervention executes two simultaneous functions. It extracts the precise tissue required for a definitive histopathological diagnosis, and it permanently cures the androgen excess. By applying this disciplined, algorithm-driven approach, endocrinologists strip away the ambiguity of postmenopausal hyperandrogenism, transforming a chaotic differential diagnosis into a precise, life-saving triage protocol.